effective and high-quality healthcare requires timely and comprehensive data gathering and sharing. Data enables health centers to outreach to patients that are lacking care. Ensuring we are reaching out to all of the patients assigned to the health center will improve many clinical measures, such as clinical cancer screening or diabetes testing. We use it to improve health center efficiency by targeting patients who need care, such as those due for annual exams or immunizations. And we use it to secure a higher return on quality initiatives through pay-for-performance programs. Each health center is asked to report on an ever-increasing number of performance measures, such as UDS, HEDIS, or pay-for-performance. In addition, many rely on grants, which require data for regular reporting. Much of the data that would be helpful isn't easily available to health centers, however. During this video, I hope to be able to share a health plan perspective on data challenges, as well as opportunities for how to collaborate with your local Medi-Cal managed care plans to get readily available data that will help health centers achieve their goals. There are many challenges with data, many of which you know. There's a reporting burden. Health plans are often blamed for poor quality by federal and state agencies. Federal and state agencies continue to increase reporting requirements to improve transparency of provider networks, monitor utilization, and investigate potential fraud. When health plan reporting is flawed or arrives late, plans may incur financial penalties. The consequence, unfortunately, then, is that health plans tend to prioritize reporting to regulators as opposed to their contracted providers. There is also a challenge with the quality of data. Health plans rarely create data. Thus, the quality of health plan data depends on the quality of data received. In Medi-Cal, half of the primary care outpatient visits are delivered by FQHCs. FQHCs are paid PPS for a Medi-Cal encounter, regardless of how well the visit is coded and documented, and as a consequence, encounters at FQHCs are often not as thoroughly coded as they should be. The impact is that health plans have trouble developing accurate reports as requested data is often missing. There's an issue with timeliness of data. Providers usually have 90 days to submit claims, which means that health plans typically think of data being complete 90 days after the service was provided. The impact is that health plans don't feel comfortable sending data prior to 90 days after the date of service. This makes care coordination particularly difficult. Keep in mind that all managed care plans are different. The data available is highly dependent on their state and provider contracts. However, there are a lot of opportunities. Even though there are a lot of challenges, health plans and health centers must figure out how to better collaborate around data if we collectively are going to be successful over the long term. To start, a health center would first want to familiarize themselves with their managed care plan reporting requirements and identify how they might be able to leverage the same reporting requirements to fit their health center's needs. Here are a few that might prove helpful to health centers. You can ask your managed care plans about these files. 834 files. These contain member eligibility data provided by the Department of Healthcare Services, or DHCS. 835 files. These contain medical coding and billing data received from providers. Managed care plans submit these regularly to DHCS. Carve-out data. Some services are not paid for by health plans, like dental, specialty mental health, or substance abuse treatment. The state gathers these data from the various agencies that provide these services and sends the data to health plans. In turn, health plans are required to share data with providers upon request. Often, by the time these data reaches the health plan, it is not always the best quality, and the health plan does not have any control over the format or content of the data, which can be particularly frustrating for clinics who are often unable to consume the data in the format provided. There's HEDIS data. HEDIS measurements are heavily regulated by the state and federal governments. Health plans have to provide evidence of these performance measures, including numerators and denominators. These measures are often the same or similar to performance measures required by health centers. You may also want to find out about other population analysis your health plans are conducting. As part of quality improvement and case management requirements, health plans conduct a variety of population analysis. These are usually health plan-wide and may not be particular to your health center, but understanding these will help you understand the priorities of your local health plan. When approaching your managed care plans, identify what your health center may be able to offer them to meet their needs. This will generate goodwill and encourage stronger collaboration in the future. Some possibilities include your comprehensive billing data. While it is difficult to code for every service provided, Find out which codes are most important to the health plan and try to improve the use of those codes. This can be useful for HEDIS, preventive care, and screenings. EHR data. More and more HEDIS measures are using data beyond typical billing code data. Since HEDIS is so important to health plans, they might benefit from additional data. Examples are your depression screening or lab results. Population management data. If your health center uses a tool outside of an EHR for population management reporting, consider sharing data feeds from this system. This will support HEDIS measurement as well. I2I was one of the first population management tools that was popular among FQHCs. Now, there are a wide variety of options. In conclusion, managed care plans need their provider networks to ensure strong and robust data. The data the plans are producing regularly for state and federal regulators could help your health center to improve operations and care delivery. Start the data collaboration conversation with your plan around what the plan needs help with. This may even help your own pay-for-performance incentives grow stronger. And talk to your plan about the type of data you need and see whether or not the regular data files they produce could address your specific needs now. Data is complicated, but there is low-hanging fruit that we can all take advantage of to move the Medi-Cal system forward. Thank you.